Today, glory to God, we are in the capital city of the Volta region, the Oxygen City. I must say we are enjoying your city. This afternoon, we have an opportunity to throw more light on our theme for this year's AGC, leveraging on the network of practice implementation to accelerate the attainment of universal health coverage. And we are going to put in our microscope on the resource constraints at the sub-district level. Gentlemen and ladies, a strong public health system is the foundation of strong health systems and the main vehicle towards achieving universal health coverage and the health-related sustainable development goals. A renewed focus on the delivery of integrated health services with an emphasis on primary health care and essential public health functions will be key to ensuring that all people receive the right care at the right time, as close as possible to their homes. This implies strategically prioritizing key interventions to ensure that services are of high quality, they are integrated, they are people-centered, and they are available and accessible to comprehensively meet people's health needs throughout the life course and across the continuum of care, from prevention, promotion and protection to treatment, rehabilitation, and palliation. Gentlemen and ladies, universal health coverage has been defined to mean all persons living in every corner of our country having access to timely and quality health services irrespective to their ability to pay at that point of care. In an attempt to achieve universal health coverage in our country, the service has realized at a point in time that the sub-district level, which constitutes the base of our primary healthcare system, is bedeviled with a number of challenges. In an attempt to address these challenges, the service in its wisdom has introduced what we call the network of practice. This afternoon, we are going to interrogate as to whether the network of practice has what it takes to resolve the challenges at the sub-district level and to better position our health system in achieving universal health for all. Gentlemen and ladies, I am happy one more time to be your host for this very important section of our Congress. I am Nana Apieje Buabin, the original chairman for Eastern Region. Welcome. Our MC has earlier introduced our panelists, so I'll quickly would like us to go through our discussion. Gentlemen, you are welcome one more time. My panel is not gender sensitive. I wish I had a woman on the panel, but without a woman, we shall still continue. You are welcome. Mr. Kwenyefu, you are welcome. First of all, discussing network of practice in the capital city of Volta region is the best thing that could have happened to any union. The reason is that the network of practice was piloted in this region. So once it has been generalized to all parts of the country, it is very important that we get to learn of the good deeds of the practice right from its home, the Volta region. So my first question will go to Dr. Ayim. Dr. Ayim, you are welcome. The network of practice was piloted here in Volta region. What is it? briefly.
So basically, the idea was that a lot of facilities and people and workers were working in silos. So what I mean is that when a patient dies in front of the hospital, they say it is not our patient. Okay. So apparently there were gaps in the health system. We were not together. So when somebody refers somebody to another place, then this group will be insulting this group, that you didn't write well, you didn't refer well, who even referred it, and all that. So one of the major issues was that after instituting CHIPS for 2 decades, which was close to client service, which meant that we wanted to move our services close to client, the second question came that we want to move quality close to the client. Now, to move quality close to the client meant that those who were far from the clients should move closer to the clients. So the idea was that when you take the health center level and the CHIPS level, there was a gap. So the network of practice was to close that gap, and now the health centers will work with the CHIPS so that inside that network will be both clinical quality and public health quality. And when we get clinical quality and public health quality as a unit of our health system, then the client can receive that. So there's the package of quality service being sent closer to the client and the client receiving it, and we sending it in a more robust design than just 111 facilities. Thank you.
Thank you very much, Doc. I think that Doc has been elaborate on it, and if you look at how he explains it, it appears very simple. And one would ask that we already have our health system structures operating, CHIPS centers, health centers, and these health centers are supposed to be providing that clinical supervisory support to the CHIPS centers, just as they also receive similar support from the district hospitals. So the question now becomes, how come all of a sudden there are these gaps? And for that matter, we have to introduce a network of practice to be able to resolve it. Mr. Kwenyefo, you are the leader of the physician assistance group in this country. A greater number of your members are operating in health centers and they are managing sub-districts. From the perspective of a physician assistant, what has been some of these gaps in the health centers that has, as it were, impeded the nation's ability to achieve universal health coverage, and for which reason the network of practice becomes very imperative?
A lot of strategies were targeted towards the lower levels and the district hospitals to the detriment of the health center. And when you come to the health center level, the health center should serve as a link between the CHIPS and the district hospitals or polyclinics that you find within your jurisdiction or catchment area. But much of strategies or policies and then human resource allocations have been targeted towards the district hospitals and CHIP compounds over the past years to the detriment of the health center. Okay. So you have come to realize that the system that is supposed to serve as a link between the CHIPS, which is the lowest level, and then the referral center at the higher level or at the primary healthcare level, there is that break in that strengthening of the capacity of the people and even human resource allocation to the sub-district level. Hence, the sub-district level has become so weakened that some of the responsibilities or actions that they are supposed to take as supervisory roles or technical support that they are supposed to give to the people at the lower level has become a challenge. And when you even look, like President alluded to in his speech, there are a lot of health centers even without physician assistants. But if these people, midwives and other health cadres, are the people managing the health centers now, and we are believing that we are supposed to go down to the lower level to build the technical capacity of these people, improve their clinical and public health responsiveness to what emergencies and the co. And it means that there is the need for us as a system or a health sector to look at the sub-district level very critically. And some of us have welcomed this idea of the network of practice, because after the Alma Mater declaration over a long time ago, this has been the only positive, deliberate policy targeted towards the sub-district to build the capacity of the people. And we believe that if the network of practice should be implemented to the core, and these are ways of what? Because currently, with the implementation of the network of practice, there is an area where facilities which are under the network, we are serving as the hub, are being provided with basic essential medicines that are supposed to be used at the lower level. So we believe that this network of practice should be implemented to the core, strengthened well, and then we believe that we'll be taking a giant step towards attainment of universal health coverage by 2020, 2030, with a population-based approach to health service delivery.
Thank you, Mr. Kwenyefu. And listening to Mr. Kwenyefu, you realize I asked him of the resource constraints, and the major one that he has hammered on has got to do with human resource. Human resource. The fact that the sub-districts and the health centers are very much challenged as far as human resources concerned. Fortunately for me, I have a lawyer here with me. You heard the human resource unit of Ghana Health Service, and we are introducing network of practice. How is the service deliberately addressing the human resource challenges at the health centers to be able to, as it were, bridge the gaps identified for universal health coverage to reach everybody?
Thank you very much. So, resources are limited, in all spheres of life. It depends on how you would want to manage the ones that you have to achieve the intended end. But when it comes to human resource for health in Ghana, we are not that bad. In fact, the supply side is churning out high numbers of professionals every year.
Okay.
The recent labor market analysis that was done brought to bear the fact that we had close to about 90,000 health workforce who are in the job market seeking to be employed.
Okay.
Which means that for supply, we don't have issues with it. Our major challenge has to do with the capacity to absorb. In terms of your budgetary allocation dedicated to personnel emolument. Okay, so let me. Sorry, I'm not trying to behave like the student. So let me. So for okay, so for every year, component of your annual budget is dedicated to the payment of salaries and allowances of staff, and that determines the number of people you can employ. And so usually when you attend meetings at the highest level, you would hear that the health sector is using close to about 80% of its budget to pay salaries.
Yes.
Which means that other services cannot be provided. And even within the 80%, the numbers that we need to run the service fully, we are not having. Okay, so that is one level of it. Then the ones that we have been able to employ, we have difficulties getting them to where their services
needed
are
the
needed.
most.
And so you find a lot of people packed at what point,
One point.
whether or not their services are needed, because of so many reasons.
All of them are in Accra.
I mean, you go to Upper East, you find that majority of staff will be in the Boga municipality. It's all over, and that is hurting the health system so much that you have people who are on payroll but cannot be found at the level where they are supposed to deliver service. And so you find that in some facilities in Greater Accra, you find that some staff have allocated have drawn up their own shift system. Because there are many. I was told that one facility, if all of them decide to go to work, they may not even get a place to stay.
But
You get it? So, yeah.
What you are saying is a challenge that has been there and will forever be there. Because people would always prefer to work in Bolga than the villages. So the question is, how are we strategically developing human resource strategies to be able to resolve these challenges with the NOP at the center of it?
Thank you. So if we are to allow systems to work,
Yes.
definitely water will find its level.
Okay.
For instance, if we allocate votes to regions,
Yes.
that this is the number of people you can employ, and this is the corresponding salary, and that is voted to you. Once you exhaust that, you cannot add on. People will be forced to move to where their services are needed. We have nice systems in place, like the staffing norm. The staffing norms talk about the number and the mix of staff that you can have at any level. But because we are not allowing that system to work, people find themselves even in areas where they have exceeded their maximum level. And it is a whole systemic issue that we would have to deal with as a service and as a country. And until that is done, we would have challenges, subsisting over government and over years, because then people will prefer working at their levels. So one beauty with the network of practice is that with the minimum that you have within your networks, as will be presented later, you are able to look at the workload of the various facilities. And so we are going to deviate from the existing practice where a staff is posted to say, Nyamebe Health Center, and you work there, whether your services are needed throughout or not. So the head of network can say that I have a spoke, and on this day the workload is high, and so you staff A, staff B, on these days, even though you work here, you go and provide service here. And so in so doing, you would address the shortfalls in number, not in physical presence, but people are always there to deliver the needed service. So that is one beauty with the networks, if we are able to make it work effectively.
So what if I understand Director very well, the novelty that the network is introducing is the fact that even if we don't have extra hands, the few that we have, we are going to strategically use them in a way and manner such that the other communities and facilities are actually going to benefit from this stuff. And but Dr. Julius, you are with the Mental Health Authority. Quite recently, in fact, this month, if you come to the Nsamam area, every community you move, you see people on the street. You understand? Now people have high levels of depression and all that, right? But then, with this network of practice, and if you are talking about a definition of health, right, we all know what it means, right? So, at the primary healthcare level, health center, sub-district level, the expertise to handle some of these mental health cases are not much available, right? So what do you think the network can do to be able to, as it were, get the right human resource to handle some of these challenges? Most especially because a course was started in Kintampo that was actually training physician assistants in mental health care. And that course had to be stopped along the line. And even those who got the expertise, they were not given the opportunity to practice. How do you think this network of practice can be used to, as it were, bring those people back on their feet to be able to provide care to our people?
Yeah, thank you very much. So the issue of having mentally ill people roaming the streets is something that is of a nationwide concern, and the Mental Health Authority has actually taken notice of that and is planning a program that is called the Dromado program. I don't know, it has an Ewe translation, which is more like offering help, like to people being to restoring their level of dignity. And the truth of the matter is that some of these people find themselves in these positions because the level of mental health awareness out there is not on the high. Mental health promotion activities have not been something that we have really placed emphasis on from inception of our healthcare system as a people. But I must say that in recent years, Mental Health Authority has been championing the cause to increase awareness about mental health issues nationwide. And for that matter, you even realize that various organizations, private as well as government organizations, are now reaching out to mental health professionals to come to their aid with regards to managing such people. Now, what the network of practice can add, or is probably going to enhance, is the sharing of expertise. Obviously, we don't have enough psychiatrists in the whole country. As a country, I don't think we have even up to 80 psychiatrists in our registers that we have produced. And out of these numbers I'm talking about, the majority are already on their way out of the country. However, leveraging on sharing expertise and human resources, as well as even technology, we can offer outreach services through telemedicine, telepsychiatric services to health centers, and even to the extent of reaching out to CHIPS compound to offer consultative services with regards to how these people can be managed. Now, beside that as well, I think that the network of practice will also bridge the gap within the community that we are talking about, whereby the few community psychiatric nurses that we have will be empowered with the necessary knowledge. And I think Ghana Health Service have been championing such a course, training people with the MH gap on how to identify some of these mental health conditions and deal with them directly, even at the grassroots level, so that they don't end up at the extreme where we see them roaming about naked in our streets. Yeah.
Thank you very much, Director. Doctor Yamba, you are welcome. As a District Director of Health, you superintend over all health activities at the district level. So for you, you know all the resource constraints. So the question is, looking at this new model, where because of budgetary allocations, we are not able to recruit all the essential services needed at the health center. And for that matter, we are going to, as it were, enhance the ability of this PA to go around the smaller facilities and provide that support. Where do you think we should place more emphasis on? Capacity building and enhancement, or it is very imperative that we deliberately increase the numbers if you really want to prioritize universal healthcare? Practically, from where you sit and the work that you do.
Thank you very much. I think we need to thank God for all what has been done as a country.
Okay.
If you look at Ghana as a whole, we look at primary healthcare services. Chiefs came in the early part of 2000 to bring health service to the doorstep to the people. From there, we tried to move through the chiefs and we're now looking at NOP, piloting in several districts, now to scale up in almost all the country. In the Volta region, 23 health centers have been earmarked to join. Recently, we were told that a team is coming from Accra to assess the level of infrastructure in these selected health centers. That has been done. And then before then, some PAs were selected, appointed, and then given orientation in Kumasi. And then we received about 16 PAs in the region to be posted to these designated model health centers. So that in health center where the NLP is going to start the day must have more than one PA. Which you agree, even one PA is, 2 PA is not enough. Yes. But for the meantime, having 2 PAs in the insect health center will help a long way. Because if one is not there, one will be able to render the services. Yes, I agree with you that yes, the human resource capacity at the health center is critical. And the PA cannot do supervision to the chief's compound. Because at the chief's compound, we may have maybe a midwife, a community nurse, maybe a rural nurse. Sometimes not even midwife. So for the health center, we expect that a team to move in a group to go to the chief's compound to provide capacity. Now, if we also look at the data as we see, look at cancer deaths as a country. And if cancer detection is not done early, you know that we will not end up we will not go anywhere. So assuming you are going out for outreach service, you go as a team, organize your resources, and go out and carry not just consultation, but also ensure that the screening for population-based activities are done. And that will also help. So for now, capacity in terms of the human resource, the staff, what career do you have at the health center? We may have a PA, some midwives, general nurses, and the numbers are not adequate. But as HR said earlier on, they need more numbers, but do you have the capacity to absorb PAs on staff in the country unless finance say that credit is available for this number? So if that's not done, we may have to look at how we can redistribute the staff that we have at the moment so the equity will be given to all areas. Now, if we do analysis of the workloads of every facility, yes, you have 3 midwives in a health center, at the end of the month, 3 deliveries. You have another health center, one midwife, 30 deliveries. We are crying for more staff, but we have not looked within our internal, within our district, within our facilities, and move some to another place so that there will be equity across board. So one of the critical things we have seen is the distribution with those that we have. That should be done and done well. But the challenge we also have as managers is that you want to move a staff and you get directly from the top. You cannot move to that place, or staff is coming transfer, already have a place to go. You, the director, you can't do much.
You are handicapped.
You are handicapped. Political authorities are there, other heads of the department are there, they are calling you. You cannot move the staff.
At the end of the day, those of us who don't know anybody.
So these are the issues on the ground that we are also faced with. The protocol, it becomes an issue of concern. That you, the district director, you have so many staff and they want to be in whole. And the outskirt of the population is at the other side. Who should not stay there? So it has to do with we've been ensuring that our policies work and work well. So the politics should not come and disrupt our decisions. That should be important. So with what you're saying, I think that the human resource for the health staff at the health center is important. The second thing is capacity. You may have the staff, but you don't have the skills to offer the comprehensive health care. How do we expect to do when it comes to going out for services or integration of services? The skill is important. A PA needs other skill to work. A medium may need other skill to work. And if you don't bring in the skills, it will become an issue of concern.
Other skills.
Yes.
Other expanded skills.
Yes.
Mr. Kwenyefu, other skills. I know that physician assistants have over the years been talking about, President talked about career diversification, skill enhancement, specialization in some areas. Do you think that at the core of this network of practice, physician assistants who are at these centers need some extra skills to be able to attend to extra conditions that previously they were not attending to, so that the universal coverage can be achieved? And what will be your advice?
As stated by other people, there needs to be a skill mix of the healthcare professionals that we have at the lower level, especially at the sub-district level, in order to achieve the main objective of the network of practice that we are implementing.
Okay.
Now, when it comes to capacity, the physician assistant has been trained in different models, and where you have been exposed to public health activities, clinical care, and all those things. But there are certain type of cares you have to go the extra mile to give when it comes to community-based and population-based care.
Okay.
Where you have to go because some of the avoidable deaths we are meeting at our various facilities can easily be prevented if the PA is capacitated and have additional skills in order to take care of those cases at a level to prevent complications that can lead even to what mortality. That is why we have done basic analysis to see ourselves as physician assistant cadre. Primarily, what should we be looking into when we're talking of career diversification or specialties? We should not be targeting the more complex issues. What are the issues that are affecting the people at the lower level? What are the type of basic specialized care that they need at the level of care? And as my other speakers have stated. Now, when it comes to dermatology, there are a lot of skin diseases at the lower level.
In the villages.
In the villages.
Yes.
And when we talk of neglected skin, tropical diseases, they are found
At the villages.
in the villages, where the people are living with multiple deprivation.
Sure.
They don't have access to basic, essential services or even commodities. So for that matter, we should be looking at getting the specialization in the skincare that we are even talking about. Because already, our people have already been diverse into that field, where they have gone to learn some additional skills in the treatment of skin conditions. And when you also go to the lower level or the community level, where the traditional healers are, where the prayer camps are, the prayer camps are not in the urban cities.
No.
They are in the rural communities. And it is in those rural communities that the physician assistant predominantly operates from. And that is within the network of practice that we are talking about. And because even at the hub level, we are supposed to link up to the traditional healers, the prayer camps, the TBAs, and the co, so that they can even refer cases to your level. So if the physician assistant cadre is even capacitated in the way of extra levels in managing what? Psychiatric conditions, it will also help. And one other issue that is affecting or contributing mostly to our morbidities and mortalities are maternal and newborn care
Issues. Okay.
Now, somebody will talk about when it comes to neonatal and maternal issues, the midwives are supposed to spearhead such issues.
Okay.
Do we have the midwives with that capacity at that level? Because when we are talking of the network of practice now, we should not be adhering only to the physician assistant, but we should be looking at the complexities and the human resource mix. You look at the laboratory people, you look at the midwives, you look at other people that can play their vital role within the network to ensure that service delivery is done. And we believe that basic additional skills in maternal and newborn care will also be an additional skill that if the PA or physician assistant is exposed to be frank, it will lead to a lot of prevention of a lot of avoidable deaths that we are witnessing at our various district hospitals. So I would say building the capacity of PAs and creating diversification platforms for them in the areas and recognizing them in the areas of psychiatry, dermatology, child care, and maternal care can go a long way to bringing us to achieving the objectives that we have set for ourselves in the networks of practice.
Thank you, Mr. Kwenye, for enhanced skills. Lawyer, Mr. Kwenyofu is talking about enhanced skills, and I understood him from a particular direction because PAs have been trained in specific specializations like dermatology and psychiatry that were advertised by the Ministry of Health. But after these people got a training and they got a certification, deliberately they have been denied the opportunity to put into practice that which they learned. So I think that Secretary wants to make a point that it is very crucial that at this particular point that we need the PA to be moving around and be providing other services. Those trainings come back on board and the people are allowed to actually put this into practice. But Dr. Yim, I have a question. This network of practice, do you think it will work?
Yeah, I hear the question like my mother, when I was 6 years, used to ask, will he be a doctor? Because at the time, he didn't have the money for medical school. But my mother believed I would be a doctor. And that's why I'm a doctor. How she did it is the concept we are using in the network. We are going to go gradually. We're going to mobilize resources. We're going to pay the Class C school fees. We're going to pay the Form 1 school fees. We're going to pay the Form 2 school fees and keep going on till we get there. So we are not going to give a summary resource. But something I want to talk about is what we mean in policy by capacity.
Okay.
Capacity is not certificate.
Yes.
And policy wants to distinguish that very clearly. And we've done that among the doctors. And I want to say it very categorical here. So when a doctor finishes school and you go into the system, when you get there, the services that Ghana Health Service requires of you, maybe cesarean section, ectopic pregnancy, whatever. The human resource director is not going to send you to school for cesarean section, ectopic, and those things. You will build capacity at where you are for it. Please, are you getting it clearly? Then you will have capacity to do the emergency cesarean sections, emergency ectopics without a certificate. Then you, as you work over 4 years, 5 years, whatever years, then you decide to go and specialize in whatever you want to specialize. And there you get a certificate. So the capacity concept that we should be very clear about in the discussions we do at the network of practice is not the certificated capacity. It is capacity to deliver a health service that is needed by the people. And another capacity I will mention before maybe I give it back to you is that there's, you mentioned something about the community. Now, when it comes to community work, the negotiation capacity is a capacity you need. I'm not talking of technical capacity. I'm talking of negotiating with the chiefs to support you, negotiating with the MP to support you, and negotiating with the MP not to force you to post everybody to one health center. Okay. Those are all critical skills. Now, that skill may not be a certificated skill, but it may be a skill that we believe that in the network, because the community health nurses have been trained in this have been trained in this, the PA can acquire it in the network, so that some of the small skills are around. Because if I'm working with a director and he has done law, I benefit from his legal knowledge not as a service certificate, a service rank or a service certificate, but then for the work we do, I will benefit from it. So when it comes to capacity, we have the certificated ones and we have the ones that we use to deliver service on a day-by-day basis that we have to deal with. And this is very critical for the discussion, so that capacity wouldn't necessarily always mean this. And let's explain this, because the doctors, when it comes to their cesarean section, we've not had a budget for training doctors on cesarean section. No budget. Everybody learns from everybody, but we render the services and they run their services. And it is critical that all the cadres understand that, so that it becomes easier to move the health system forward the way we envisage the network of practice to be. Thank you very much.
Thank you very much, Doc. I think that we very much understand your point that capacity is not about certification, but our practice is said that there are some skills that even if you have and you want to put them into practice, you need certification backing you to be able to actually do that and to get that legality.
Yes, so like this certification thing, and why I'm strong about it is that I perfectly agree with you. But I'm saying that the service we are giving, let me give you an example. Presently, we are training, if I ask for the budget for study leaves in Ghana Health Service, it's a huge figure.
Okay.
So people are going to do dermatology, this, that, and they come back. Now, you were seeing 100 patients. 3 of them used to have dermatology problems as a physician assistant.
Yes.
Though you were referring the 3, then we make you go and do a dermatology course and you come. What it means is that for Ghana Health Service, now you are capable of seeing 103 clients without referring the 3. But you are still a physician assistant working.
Okay.
But if you say now you've come back from dermatology, so you can only see 3. That means I have to look for an enrolled nurse to see the 100. So now we have to pay an enrolled nurse to see the 100, and then you have 3. Then another ENT person will have 3 ENT. Then another person will have this, and they are packed. Then I'm saying that at policy level, we may need to look at. Hello.
Please.
No, these are the policy junctions. Hello. So these are the policy junctions we are, because when we take our 10 top diseases, hello, when we take our 10 top diseases, when you go and look in your data, you see the 10 top diseases. We have a per capita of 1, which means 30 million people, every Ghanaian comes into contact with us once in the health system. That's the average. Now we are saying that we have said in the theory of change that these 10 top diseases, every physician assistant can deal with it. That is our theory.
Okay.
So these 10 top at the network level, we are done. Okay. The extra ones we will do. But what we are evaluating most of the time at our performance reviews and is that how is these 10 top diseases being delivered? And those are the issues that we are dealing with. So I'm okay with the stress, but I'm just saying that we still are working very hard that in the 10 top diseases and in the maternal issues and all those things, we deliver it in a way that eventually we can get more of our people coming into our facilities, and we shall also get more skills in making it so palatable that going to prayer camps, going to all the other competitive areas become a problem.
Thank you very much. My last round of questions for the sake of time. That Ayamba, let me come straight to you before I go to Peter. What 2 things do you think we should expect from district directors to ensure that the network actually works? 2.
The first thing, to support the PA and his team with the needed resources.
Okay.
If we joke with that, then a PA will be handicapped.
Okay.
Secondly, there must be a way to support transport system at a sub-district level.
Transportation system
Yes.
at the sub-district level.
As I'm saying, if you are in a bigger health center with about 30 or 50 staff, and you are going to a chief's compound with a team of 3 or 4, are you going to use a motor?
Okay.
So these are the units on the ground. So we must look at that issue very well and support the sub-district to work well. Then what I would like to add is that the service should also define some motivation or innovation for the workers at the health center level.
Okay.
Now,
So as for this one,
so
Sarah is
I
listening.
want to add that if you look at the hospitals, doctors come on locum,
Okay.
they are paid. With the IGF,
Okay.
a PA who accepted to work in a health center running 24-hour service, there's nothing extra to get.
Okay.
Even your annual leave, sometimes
You are denied.
it's a problem. So these are the reality on the ground.
Okay.
Now you have also a midwife delivering 60 people every month, and you go and see the midwife, the foot are swollen. Yet there's nothing motivation. In the Upper East region, I was there for about 20 years, and then Dr. Wuno was there. If you look at the workload analysis, Upper East is still one of the best in terms of midwives per population. And because he introduced some kind of motivation for district directors to sponsor midwives, and when they come out, they should stay in the district where they left for the school. So when it comes to midwives in the whole country, sometimes Upper East is better off because of that kind of innovation. So the service should also look at how can we motivate the PAs and other cadres at the health center who are ready to work and work and work to improve health outcomes. Otherwise, they'll burn out and they will lose them.
Thank you. Thank you, Director Ayamba. So when you go back home, say to your district director the support that you need, the transport and the motivation. And Peter, what two things would you expect from PAs to ensure that the network becomes a success?
Yeah, as physician assistants, as we are expecting a lot from the authorities, we should also be ready to work the extra mile.
Okay.
To put in our efforts. Let's bring our skills to bear so that people can actually know your wealth. We are supposed to actually give capacity to the people.
Okay.
We are supposed to supervise them, help them in their budgetary allocations and coming to budgetary items, help them with other requisite skills that they need in order to operate within the network.
We should position ourselves well.
We should position ourselves very well. And as President stated, the second one, let there be personal development. Let us crave for development whilst awaiting for policy makers to bring across certain things or policies or strategies that can help propel the physician assistant profession to the higher level. But where we find ourselves now, let us do our best and brighten the corner where you are.
Thank you, Mr. Kwenyefu. So, as he said, position yourself at the center of the network. Don't be that physician assistant who care less about your facilities at the periphery. Don't always be concentrated on things in your health center. And then, the second one you talked about, personal development. CPD Brebi, men send this guy. Someone register me. Come for the CPD. Develop yourself. Dr. Yim, what two things?
Yeah, so I'm happy. In fact, when we started the network of practice, people were not discussing it at this level. Sometimes Dr. Yim will just go and give a PowerPoint. So I'm really excited to come here today to hear it the way most of you are talking about it. It shows that it has grown. And for those of us who started with it, we are very, very excited. And I really thank the physician assistant group for making it. In fact, if the director was here, she would have been very happy. She wouldn't have even talked. She would have said, let me sit here and let the people talk, let me hear. Because yesterday she told me that, Dr. Yim, are we not hearing ourselves too much in this network of practice? Can we hear other people speak? So, local policy, like he said, that if you are in the region or if you are the district, you can still create small incentive concepts, not necessarily from the national level. Like he said in the Upper East experience, it wasn't a national level thing. And we are capable of doing it at our level. Let's do something small at our level, at the national level. When we come and see that example, is when we use it as policy and roll it across the country. So be bold and take some initiatives within the rules to do the network in a way. We are learning. So we don't have a fixed phenomenon in the network. And we are going around looking at how people do it to write and review our policy. So that's what I will encourage you. The second thing is local resource mobilization. Resource mobilization. What we are saying is that during the COVID, we had a lot of experience where local people were ready to help because of the way we presented it. So we know in the country, various chiefs, various MPs, various people are ready to help so that you can go into that negotiations with them, attend some of the assembly meetings, your unit committee meetings, so that some of the resources that are coming can also come into the network, and then we'll get it better. Thank you very much.
My last question to Director Obriyebo. Director, at the center of every policy is a human resource. Fortunately, you sit at the top when it comes to health human resource in this country. District Director made mention of the fact that their ability to allocate resources to the communities that need them most at times is impeded by hands that are higher than them. What one thing do you think your office and those who represent you at the regions and at the district should be able to do to ensure that the right resources get to the right communities for the right impact to be made as far as the network is concerned?
Thank you very much. I would say that hand touches everybody in the chain. So
Including
it's not as if it's just at the, in fact, at the lower level, it's even soft. But at the national level, you are dealing with the top how do you call it, office holders, so you can understand. But within that constraint, we try to do our things professionally. I don't know, when you were talking about resourcing the networks, I wish I was going to have an opportunity to talk about the fact that it is our responsibility to make sure that the networks are staffed appropriately. And that is why recently, out of funding we had to engage about 250 PAs. We are working on their transition onto government payroll. Good. So that is what we are doing. It is our hope that each hub will have a minimum of 2 PAs. Sure. As a director of HR, I don't want to hear that I'm working 24 hours. Nobody works 24 hours. Sure. And so we want to ensure that if we want the hubs to operate 24 hours, then definitely there should be human resource that will man that facility. So there will be some form of shift system for two PAs. One person can take a leave, one person can go on relieving duty, and that. We also talked about service pack for the various levels. And that has been missing throughout our discussion.
Okay.
You see, at health center level, by design, there are certain things you cannot do.
Sure.
You have a limit.
You have a limit.
And that is the level of training of PA.
Definitely.
Good. And so, by expectation, anything that is above your level of practice, you're supposed to refer. And that is supposed to be the arrangement. So you do not take certain cases upon yourself. When the organization has prescribed that for ABC, push it up. Sure. Unless there has been a deliberate effort to give you that skill to attend to that. Sure. And we do that through task shifting and task sharing. Sure. It's not about specialization. And so when you're talking about people going to do dermatology, it's not specialization. It's tax sharing or tax shifting.
But nowadays,
I'm coming. And you are giving certificates. And because you are performing additional duty beyond what a normal PA should done, you need to be compensated for that.
Definitely.
You get it? So I think the discussion, we should be clear. Whenever I meet you and I'm talking about specialization in dermatology, and sometimes I get confused. And so you can be seeing, if you don't have that skill, and we provide that skill and we give it as a certificate, we empower you through your job description to perform that duty, and we put you on appropriate salary level, that becomes part of your duty. You get it? For which you should be paid at the end of the month. And that is the aspect that is missing in the current engagement, which we'll be working on. And so for us, we will make sure that staff have the requisite capacities, the skills to perform at the various levels based on the defined service package, so that at whatever level you are, you'll be comfortable in performing your assigned duty. Thank you very much.
Thank you very much, gentlemen and ladies, for your attention. So it is very clear that the physician assistant is going to be at the center of the network of practice, and that the network of practice is a strategy which aims at strengthening our primary healthcare system. A strong primary healthcare system will help Ghana achieve universal health coverage in the next 6 years. And I'm happy to announce that physician assistants are at the center of this network. Let us consolidate our presence at this center so that a time will not come where physician assistants would have to be pushed elsewhere for another cadre to come and stand at the center. Let us prove our worth even as we are implementing this network of practice. Thank you very much for your audience. Thank you very much, gentlemen on the panel. Thank you for coming. Mr. MC, we are done. Oh, time. Mr. MC, do you have time for questions? Just 2. Oh, no crap. Okay, so I'm told 2 questions, so I'll pick the first one from Eastern Region. Hey, why are you being biased? The first question from somebody from Eastern Region. Okay, Mr. Samuel, we have to come forward with your question. And then my lady up there. Please be, as much as possible, be straightforward with your question.
One.
Thank you very much for the opportunity. My name is Samuel Yafe from Eastern Region. Yeah, I have actually enjoyed the discussion, and I'm grateful for the panelists. I mean, various key points have been raised. My little concern has to do with the aspect of capacity building of the PA. I mean, when we are talking about the training and their capacity. I have observed for some months or years now that some of the schools that were training physician assistants have been closed down, particularly the universities. Then again, I've also observed that some of the trainings that used to be organized for physician assistant, for instance, in basic surgical skills,
Yes.
which equip the PA to do maybe circumcision, wound suturing, and some other even wound management and other things, have also been pulled out. And it creates a concern because if you are thinking about building the capacity of the PA at that community level, these are issues that come to the PA, and these are simple things that are not complex to be referred. And I mean, over the years, PA have been at that forefront, delivering this diligent service that we all know of. I bet to know maybe what happened. And so we are only just, I mean, in thinking about policy to actually enhance training and capacity building. Maybe if it has to be a great concern because it appears we are weakening the training rather. We are reducing their capacity. And it's a very concern if we are actually relating it to this network of practice. Thank you.
Thank you, Doctor.
Thank you.
Dr. Julius would like to respond to that, but before that, let's take the second question from our lady.
I think he has spoken for all of the people.
Last question.
Thank you very much. My name is Peggy Nkiasen from Southern District. Please, when the HR was talking, he talked about situations where PAs or staff want to be at the urban areas. And then he mentioned that there are reasons. I also want to state some of the reasons. One of them is lack of accommodation in those low areas. And if there's no accommodation, how would the PA go to that place to go and stay there and be able to work there? Sometimes, not that the PA is even looking for free accommodation. Apartments to rent with their own money, and they don't have nothing in that community for the PA to stay and even do the work.
Yes.
So it's not like
People
the
don't want
PAs don't want to go to the, it's the condition in those communities.
Thank you.
That is what the PA is looking at, to be able to go and stay there and do the work.
Thank you.
Please, that's my first comment.
Please make the last comment very snappy.
Last comment. Please, I think this is a national problem. It's about the rural and then districts that are categorized under rural and urban.
Yes.
I think the categorization is unfair. You go to certain sub-districts and it's very rural, but they've categorized it under urban, which is affecting them, and they are not getting certain motivations that they have to get for being in a rural community.
Thank
Please,
you
thank
for your
you.
concern. I'm sure your 2 concerns would not need a direct response.
Yes.
Thank you.
Okay. So with regards to the area of curtailing the efforts of the physician assistant to take care of certain kinds of cases, for instance, do wound suturing, and even taking care of mentally ill patients. Let me speak for the mentally ill patients. There's been, no one has said that the physician assistant at the sub-district level should not attend to mentally ill patients. In fact, the training per the MHCAP is to even empower the nurses to be able to attend to mentally ill patients. The MHCAP has algorithm that you can follow, and once you follow it, it leads you to a particular kind of condition, for instance, psychosis, and it even indicates what kind of treatment should be initiated in that case. But the feedback after training some of these districts and sub-district personnel is that once a mentally ill patient comes and a nurse draws the attention of a physician assistant, says, "Oh, go to psychiatry unit." So once you are not practicing it, you lose the skill. That is how nature is. Anything that you do not use, you lose it. Even at the tertiary psychiatric hospitals, we have physician assistants, and we allow them to go ahead, attend to mentally ill patients. To the extent of even new and freshly ill patients, they get the chance to attend to them. So really, nobody is saying that don't apply the skill you already have. It may be the issue of certification. That's what Dr. Yim was talking about. That capacity is very different from certification. And so if you have the capacity, and in fact, during training, all physician assistants, they do surgical rotation. They do, psychiatry rotation as well. So we expect that at least the basic things that you need to do, you should do. However, just like Director HR2 was saying, you should know your limit. That is not the time you are going to apply electroconvulsive therapy to shock someone. It's not in your purview as a physician assistant to do. So you should know your limit, and as well you should know your capacity as an individual practitioner. Thank you very much.
Thank you very much one more time, gentlemen, for your time. Let us clap for our panelists, gentlemen and ladies. Thank you. No, the ladies' issues, they were not questions. The training institutions. They don't have representation here. You understand? Gentlemen and ladies, I have spoken to my panelists here. None of them is in a capacity to respond to issues concerning or emanating from the training and licensing authorities, right? So let us not push them to give us responses that we might end up not being happy with. Thank you very much for your understanding. Thank you. We have other presentations, and I'm sure some of these issues will pop up. Thank you for your time. Thank you, gentlemen.
Thank you, Mr. Boabin, and the panel members. It's been very erudite, and we hope we'll have more of this going forward. Without wasting much time, we have one presentation before we go for lunch. So shall we invite from Timothy Frank Bedu from Infotech Limited to give us a brief presentation on their product. Then we can go for lunch. Thank you.
Good afternoon, everybody. Hello, everybody. Yeah, I understand that you've sat for long. I also understand that you want to go for lunch, but allow me just 10 minutes or maybe less to talk to you about some of the things that are happening in your consulting rooms, offer to you some solutions that you can use in your consulting room. My name is Timothy Frank Bedu, and I represent Inotech International. Inotech International is a French pharmaceutical. I'm trying to get the connection, if you can do it for me so I can start the presentation. Inotech is a French pharmaceutical, and on the Ghanaian soil, we've been here for the past 14 years. We have registered 4 brands, only 4 brands: Totima, Polygenax, Flebodia, and Idios. I'm sure these brands have been successful on the market because of your support. And I want to use this opportunity to say thank you very much. If you can clap for yourself, I really appreciate it. Thank you so much for your support. Since its introduction into the country, the PAs have been at the forefront prescribing these products for us. More importantly, I want to talk to you about one very important thing: vaginal infections. And why do our patients come back even when we have followed the protocol? Even when we have done what needs to be done, we have given the medications that we are supposed to give as primary caregivers. Why do they keep coming back with relapses and recurrences? And I'm sure that if we are to have a panel discussion like we did right now, there will be a lot of reasons as to why. I don't know what's happening. Okay, so laptop is connected. Okay, so I was saying that if we are to have a panel discussion, we would have a lot of varied opinions. But in this particular presentation, we'll see three main reasons why our patients are coming back with relapses and recurrence. And we'll try to see how we can adapt our prescription habits, or we'll adapt the way we look at things so that we'll be able to capture these patients back so that we don't get a lot of relapses and recurrences. You would have to project because it's in extension mode. You would have to project. When you project, I'll see it here. Please, do you need any help? Okay. Let me start my presentation then, since the technical people are not helping me. Let's talk about Kukua. Kukua is a patient who comes to see you in your consulting room. She is a 32-year-old woman, married, sexually active. She comes into your consulting room. She is having a recurrent vaginal infection. In her first incident, she saw you. You gave Miconazole, 400 milligram, one at night for 3 days. Now, because she has come back, when you did vaginal examination, or what she told you, she says that there is a thick, cheesy. Please move on to the case study so that we can quickly move here. Okay. So I was talking about, please move back. I was talking about a sexually active single 32-year-old woman who presents to you a vulvar irritation, genital itching, and non-smelly discharge. And that has been bothering her for several days. She explains to you that she has vulvar inflammation, vaginal edema with thick, cheesy, creamy discharges. And I'm sure with just this information, you should be able to make a particular diagnosis based on that. Next slide. And with this in mind, I'm sure most of us were able to come to a diagnosis, but generally, if the doctor decided to give Polygenax for this patient because of history and laboratory findings, it showed that she has complicated VVC with non-albicans VVC and also has suprabacterial infection. Kukua is already used to the 3-day medication, so she was surprised that doctor decided to give Polygenax treatment 12 days. And she's comparing with the 3-day treatment course and insists on reducing it to 6 days. Is it possible? If in the presentation we should be able to discuss that. This patient tells you that she's almost due for her period and requests to know the possibility also of remaining sexually active whilst using Polygenax during her treatment. And the most important question, should her husband be treated as well, even though he doesn't exhibit any symptoms whatsoever? These are the questions that I want to address in my discussion. But generally, if we are talking about vaginal infections, please move on. We have two cases. We can have the non-infectious form and the infectious form. The non-infectious form generally because of the balance of the vaginal flora, because of personal hygiene, estrogen deficiency, and a whole lot of other issues or practices that a lot of women do. But the infectious form, we can have the endogenous when generally one pathogen decides to outgrow the others, or the exogenous when there is an external contamination or external pathogen introduced into the vaginal flora. But most often than not, what we see is the infectious form, because these are the ones that will persist longer enough with symptoms for the patient to come into the consulting to see you. Please move on. And inadequate management of these acute vaginitis generally impact the quality of life. We can talk, please go back. We can talk about, go back, stay here. We can talk about anxiety and depression. We can talk about decrease in professional activity. We can talk about the mental health, and more importantly, sexual activity. She's not comfortable with herself. The place is inflamed. She would not allow her man to be with her. And it is something that impacts the quality of life of most women. Please move on. Please move on. A lot of medications are available in the primary care level. We can talk about the azoles, we can talk about the oral triazoles, we have the fluconazole, atroconazole, ketoconazole, which are available and accessible to us. We use these medications for the management of VVC. Patient comes, we try to use various generics, various brands to manage it. The less used form is the polyenes, nystatin and amphotericin B. And we want to see what is really happening after the prolific use of the azoles. One of the things that is happening, please move on to the next slide, is that 50% of women are having relapses. That is to say that if you are treating 10 patients with VVC, at least 5 of them are likely to come back with relapses and recurrence. Out of these 5 that are coming back, 1 is likely going to have more than 4 episodes per year. And it's unimaginable for a woman to move from one consult room to the next, necessarily trying to look for a solution for simple VVC. Next slide. So the key question in this particular discussion is that why do our patients come back? I have done what I'm supposed to do. Why is this patient come back? And if we are to discuss it, most of the answers will be based on the patient. Patient perianal hygiene, patient not completing their drugs, patient this, patient that. But in the consortium, there are 3 things that we can correct, and we'll discuss them briefly. Let's go. Azole resistance. The fact that we have prolifically used the azoles, now the azoles, the pathogens that we are using the azoles for have developed resistance. Disruption of the vaginal ecosystem and the diversity. Now we are not having just one strain as we used to. It's very diverse in that sense. We'll look at the current statistics. Please, let's move on. Resistance. It is interesting that when we talk about VVC, 80% of the pathogen is basically Candida albicans, very common. Candida albicans responds very well with some azoles. But it's interesting that in a study that was done in 2016, revealed that miconazole resistance has risen up to about 54%. So your person comes to you with VVC, you shooting them miconazole 1 brand, miconazole brand 2. Basically, what is happening is that you are not going to get result. Patients just keep jumping consult room to the next. And then the less common one, 20%, is the Candida non-albicans, chiefly Candida glabrata. And this one is not going to respond to the azoles generally. Resistance for cotrimazole is up to about 50.5% for that matter. And generally, that justifies the fact that we need to change from the azoles to molecules that pathogens would respond very well. In another study that was done, you would see that if your flora has both albicans and non-albicans, for instance, if you want to use miconazole, you need to increase concentration up to about 67 times, the same with miconazole. But it is interesting that the old nystatin molecule had the same MIC for both albicans and non-albicans. What it means is that if you have a flora that has both albicans and non-albicans, polygynous does a better job. Let's go. Secondly, lactobacillus. We agree that lactobacillus is very key in when you are treating vaginal infection. So it serves as a defense system, and it's anything that would disrupt that particular flora would make the patient necessarily come back. But it is interesting to know that some of the things that we do, even as women, please next slide, some of the things that we do generally would exacerbate the issue: stress, age and changes hormonal levels, inadequate hygiene. A lot of the things that we do would affect the vaginal flora. But that is not even the problem. The problem is that most patients will come with vaginal infections. Some of the medications that are introduced locally and sometimes systemically generally have detrimental effect on the lactobacillus. In a study that was done, please let's move on. In a study that was done, looking at the major strains of major molecules that we use, Miconazole 400, this is a very popular brand, metronidazole combination plus metronidazole plus miconazole. Now I think they add lactobacillus to it as well, and clindamycin, ketoconazole. These are brands very popular on the Ghanaian market. You would see that miconazole disrupts one major lactobacilli strain. So what it means is that patient is well. If patient goes back to the same parental hygiene, sexual partner, panties, and a whole knot, what happens is that chances are higher for her to come back with a relapse or recurrence. Metronidazole and miconazole, even worse, destroying two major lactobacilli strains. Now, it is interesting that we add lactobacilli spores to this to compensate for that. Not necessarily to re-establish it, but to compensate for the loss that the drug has caused. It is very, very important to take note of that. So if someone says that, okay, I have lactobacilli spores, it's you would have to ask yourself, why put metronidazole or antibiotic and bacteria in one petri dish, expecting it to grow? Something for you to think about. So, Polyginax, as you see, respects all the three major lactobacilli strains of innate treatment and then ensures that it restores back to normalcy. Let's go back to the next slide. I didn't see you. Etiology or diversity in etiology. I'm sure that when I talked about kukua, most of us necessarily you don't need to, I'm done. I'll have about 3 or 4 slides more. If we talk about the etiology, you would see that most of us may have guessed that kukua was having candida or VVC. But unfortunately, the lab findings saw that there was some bacterial infection associated with the VVC. And that is true for most of the cases. Patient gets azole preparation. The fungal component is dealt with, the bacterial component is not dealt with. Chances are high she will come back with a relapse or recurrence. It is said that 2 in 3 infectious vaginitis do not have a pure fungal etiology, and that is why we need to consider a broad spectrum preparation. And most of the preparations that we have are mostly metronidazole plus antifungal. Generally, metronidazole has a limited spectrum in terms of just taking care of Gardnerella and Trichomonas in that sense. Polyginax has one antifungal, which is nystatin, and we've seen the advantage of nystatin in Polyginax over the azoles. We've also seen that it has 2 antibacterial agents, polymyxin B and neomycin, which allows you to have an even wide spectrum than the metronidazole and some of the combinations that we have there. So anytime you are using Polyginax for a patient having VVC, you are sure that if it is albicans, you are covered. Non-albicans, you are covered. If you have some strains of bacterial in there, you are also covered, which allows you to have one of the widest spectrum in the Ghanaian market. Please, let's move on. Again, in terms of clinical efficacy, from day 2, patients are supposed to have a drastic reduction in the clinical symptoms up until the end of the treatment. It is important for us, for you to tell your patients that in day 2 or at day 2, they will get better. But they need to continue the treatment for the whole of the 12 nights to get better. Let's move on. So another person is probably asking, why do I need to use a local preparation? I use my fluconazole and then my patient don't like inserting. In fact, it is not very comfortable mode of administration. But by using a local preparation, you are able to deliver sustained concentrations of the drug to the infected site. You bypass any form of systemic toxicity. You do not have any form of gastrointestinal issues. You induce better compliance for most patients. And this gives a better advantage than the systemic molecules that you would want to use. Please, let's move on. My last question, then I'm done. Let me ask this question and answer it for you. Can polyginax be used during pregnancy? Every drug is not recommended in pregnancy. I must say that. So every every drug should be used with caution in pregnancy. So in our leaflet, we have stated that polygynous is not recommended in pregnancy. However, you must note that this is a precaution just like any other drug that we are giving. Polygynous is not contraindicated. Polygynous can be used in pregnancy without any issues. Our data shows that there is no clinical defects or birth defects or fetal toxicities associated with this particular molecule. Please, let's move on. In summary, we've looked at how polygynous respects vaginal flora. We've also looked at Pukwa's issue, how she wants to reduce the treatment duration from 12 days to 6 days, which is not possible. She wants to cover the whole life cycle of the fungus to have effective results. Again, she's going to get better after day 2. In terms of menstruation, polygynous does not have any issues with menstruation. If patient is using it and her menses comes, polygynous efficacy would not be hindered too. Sexual activity. Patient, if what you are treating is not STI, patient can comfortably use polygynous and have sexual activity for that matter. But what we don't encourage is that using latest condoms or diaphragms. What happens is that dimethicone in polygynous will destroy the material, the latest material. So if you are using it to prevent pregnancy or diseases, it will not work. Polygynous will destroy it for you. But if you want to have sex, polygynous would not interfere with your sexual activity for that matter. In fact, this is one of the fastest dissolving drugs. Within just 5 to 10 minutes, it absorbs moisture from the vaginal environment, bursts and releases content. Let's move on, and then I think we are done. So polygynous is supposed to be used 1 at night for 12 nights. Patients do not need to stop treatment during menstruation. Let's move on. And we have seen all the 3 stages, how polygynous meets vulvovaginal candidiasis challenge. We also seen how it treats whilst respecting the vaginal flora. It doesn't destroy and put something there hoping that it will become viable, and it treats all vaginitis regardless of the etiology. All the references that are used in the treatment in this particular discussion, next slide, all the references that were used in this discussion are shown. I'm sure the last question that will be asking, how much is polygynous? Before I tell you how much is polygynous, let me just say that you need to think about cost. Cost is important, yes, but you should think about it this way. Quality is the best way to reduce cost. Don't let your patient come and go, come and go, come and go before you recommend a quality product for the person. And with that, I want to say thank you very much for your attention. I hope I didn't take so much of your time. Ask me a question. That was my question. Okay, polygynous should cost your patient around 130 Ghana cedis. Oh, I didn't add the only. 130 Ghana cedis only.
Oh, are we going out just like that?
You can ask me a question as you are going out.
Please. Ask the questions.
Ask your question even as you go out.
Okay. Thank you, Mr. Timothy. We are coming back in the next 30 minutes to take the next presentation.